Hello, my name is Ian Ayre. I'm a teaching assistant at the Human Anatomy program for the University of Utah. I do dissections on human cadavers, so you know I'm valid. um, but yeah, I get to give a presentation about the mechanics and kind of going into depth on the cardiac conduction system. So I wanted to make a YouTube video about this because this information's not on YouTube. If you look up the conduction system of the heart, you're just going to find 10-minute videos going over SA node, AV node, His bundle, or His-Purkinje system, or Purkinje system, and then just like, that's it, right? There's nothing going in depth. You won't get this on YouTube. The only way to find this information is to go out and read papers, scavenge the internet, scavenge Google Scholar, find everything you can, and it's not like easily accessible. So that's why I'm making this video. So we're going to be going over the cardiac conduction system. We're going way beyond what the anatomy textbook will tell you. We're going to be talking about some physiology, things like that. Whoa. Okay, so going over the plans for what we're going to talk about today. We're going to be going over an overview of the CCS, the cardiac conduction system. So really like what you should know watching this video. If you don't know much, you can just watch like a 10-minute YouTube video about it. There's a million of them going over kind of the basic stuff. And then after that, we're going to be like, I'll be really quick. And then we're going to be talking about the anatomy of the CCS as we know it. So what do we know now compared to the anatomy textbook? Like, where are we at now, right? After that, we're going to be talking about the physiology of conductive tissues. We're going to be talking about why are they conductive, how are they different from just the normal myocardium, action potentials, things like that. Next, we're going to be talking about an overview of development. So the development of the heart is very complicated. It's very weird to get your head around all the folding and twisting that goes on as the heart grows, but it is very important. Embryology and comparative anatomy, but those two together are what make a good understanding of anatomy. You need those two on top of anatomy to really understand why things are the way it is, right? We don't, especially at the U, right? We don't memorize anatomy. We know why the anatomy is the way it is. So we have to understand some of the development of the heart to understand why the conduction system is the way it is. After that, we'll be talking about the AV node, kind of going into depth on really like more into depth on the structure of the AV node, how it works. After we talk about that, we'll be talking about what's called the AVNRT, or atrioventricular nodal reentry tachycardia. So atrioventricular nodal reentry tachycardia. The mechanism of that reentry tachycardia is really significant for AFib, which we'll be talking about at the end. So kind of that mechanism we'll talk about. We'll go over how it works, and it'll make more sense why we talk about it, and why it's so important when we talk about AFib. After that, we'll be talking about these conductive ring tissues. So it's kind of like these extra weird sites of conduction or conductive tissue that is, extra, not part of what we learn. It's not even touched on. You'll never like hear about this. It's just these extra sites that have to do with kind of the AV node, and it's like these extensions. Basically, they form these rings of conductive tissue. For the whole video, I'm going to be saying conductive tissue, so don't get that confused with connective tissue. I'm always going to be saying conductive tissue. I might mess up and say connective tissue, but conductive kind of is like that nodal type thing that's going to conduct the tissue or conduct the signal, right? After that, we'll be going a little bit over the His-Purkinje system. I hope it's not Purkinje. I've heard a lot of people say it different ways, but I'm going to say Purkinje. But yeah, we'll be going over that. We won't go too far into depth. We'll talk about why it kind of is the way it is in terms of really quick conduction, and then we're going to be talking about these things called ganglionated plexi, which are essentially the extrinsic innervation of the heart. So it's kind of like these sites of the parasympathetic and the sympathetic system where they sit on the heart and kind of their significance in a clinical application. After that, we'll be talking about the intraoperative CCS mapping for congenital heart surgery. So if you think about congenital heart defects, there's a lot that goes wrong in the development of the heart. You could have like a 3-chambered heart. You could have tons of different things twisting and folding in wrong ways. So it's really important to have an ability to see where the conductive tissue is so that we can avoid it in properly doing surgery, right? If you're trying to reform the heart into a functioning heart, you don't want to cut right through the His bundle when you're trying to like patch something together, right? You don't want to just like cut right through it. So you have to know where it is. So that's why intraoperative mapping is really important for congenital heart surgery specifically. And then lastly, we'll be ending with a really an in-depth conversation about atrial fibrillation. It's extremely interesting. It's so common. It's kind of like cancer. Like we'll talk about it, but AFib is essentially inevitable with the way the heart is structured. So it's going to be, we'll talk about that. Overall, we're really trying to understand why, right? We're not just going to talk, this is the way it is, this is the way it is. Everything has a reason for the way it is, right? There's always a purpose, there's always a function for a structure. There's always a why for the way something is. Something that's been like really confusing me is why for the ring tissues. So we'll try to talk about that. It's still very confusing, but we'll really be talking about why things are the way they are. That's like the most important part. All right. Flashbang. We've all seen this before, hopefully. Okay, so this is like that basic, super basic. You see it over and over. This is the CCS, that cardiac conduction system. We have the SA node. I'll just use my mouse. We got the SA node right here. And then we have that Bachmann's bundle that goes, takes the signal from the right atrium to left atrium. And then we have the AV node. And then that kind of penetrates through that fibrous body of the heart and then goes down. We have like the His bundle right here. And then it kind of splits up into that right and left bundle branch. And then you have the Purkinje system that really, and that like conducts the signal to the ventricular muscle. And as we know, SA node, pacemaker, sends the signal down. AV node is kind of slowing that signal so that you can have like get all the blood out of the atrium, all of it into the ventricle. So it slows it, and then essentially conduction just speeds up quicker. And so you have like this, essentially by the time it reaches the ventricle, it's like everything's getting at the same time and then contracting. So we should have a good idea on that. If you want more in depth, go watch another YouTube video. There's like a million of them. Whoa! What does it actually look like? It's slow. Okay, what does it actually look like? So here we're looking at a 2009 paper called "And the Beat Goes On: The Cardiac Conduction System, the wiring system of the heart." So this is kind of starting to poke at the idea of the SA node being more than just this little dot. It's really like this spanning structure from the superior vena cava to the inferior vena cava. I'm gonna use this. My girlfriend made me this awesome heart vase. But really, like, I think it'll help maybe to look at this. You can also look obviously on the screen. But instead of just being something at this area right here, it's something that spans the SA node as a structure spans the entire length of the superior vena cava to the inferior vena cava. So it's not just like this dot. Like it's localized here, right up at that like crista terminalis, which is like this groove between the auricle and the superior vena cava, kind of. It can be localized right up in that superior vena cava area, but it's really this spanning structure between superior and inferior vena cava, that is like that site of pacemaking. So it's not just that first. It's not just like that localization. It's a spanning structure. Looking at another look. So this is from a 2021 paper, and you can see down here. It doesn't really depict it like going all the way down here, but we can see like it's a lot larger than what we kind of talk about, right? it's like this more spanning area. And then these are kind of talking about like perinodal areas and adipose tissue. Really just kind of saying like the red is the sinus node. But again, going back, we do see like, I think this was in like a rabbit heart, this one, and then these are kind of different, like different studies that were used to look at these, but it is like this spanning structure that's a lot different than what we see. Oh my God, we got to go through this. Oh my God. Okay, yeah, but it's not this, right? It's not this at all. It's really this spanning structure. Oh my God. All right. So yeah, really spanning structure is kind of the most important thing when we're thinking about the SA node anatomy, right? It's not exactly the way we see it. Next, we're going to be talking about, next we go on to the AV node. So here we have a paper. This is actually, it's kind of wrong, but it's not from this paper. It's from a different paper. Everything will be in a reference slide at the end of the presentation, but essentially what this is saying is we have this area. So if we cut away part of the auricle and cut away part of the vena cava, so like really looking into that right atrium, we can see we have coronary sinus right here, and then you have the tendon of Todaro, and then you have like the crista terminalis right here. So really we have like this, like the triangle of Koch is what it's called. Or Koch? I don't remember. Koch? I'll probably say Koch. But essentially you have this triangle of structures that go in to like that central fibrous body, and then that is where the AV node is. And then taking a look at this area, moving over here, this is more looking at the specifics of that AV node. So you have the right ventricle right here and the tricuspid valve. So like looking down this area where my mouse is, down here would be right ventricle, but then this would be tricuspid valve. And then sitting on top of that tricuspid valve, so like right here, we have this just kind of sheet of fibrous body. You would have the septum kind of like right here. And then this would be essentially for this fast and slow pathway. We would see fast pathway coming from like here to here, right? And then we would have slow pathway going from like here and then looping down like that, right? Around that coronary sinus, so like looping around. And really, these are kind of arbitrary, or they're not arbitrary, but like the slow and fast pathway are just kind of the directions that they go, right? Like something coming from here to here is going to be a lot faster, and it's going through like atrial muscle, so it's going to be a lot faster here, right, than having to go from this area all the way down here, all the way around, and then into this inferior nodal extension, and then to the CN, which means compact node. So looking more into the kind of anatomy of the AV node, which is what this diagram is depicting, we have kind of remember like where we're looking, right? We're looking into this kind of like closing triangle, right? Inferior vena cava, superior vena cava is like up here, right? Fossa ovalis, kind of in the middle of the right atrium, or like the interatrial septum, and then coronary sinus right here. And then if we're traveling, like the signal's traveling through the atrial muscle, right? We're gonna get into this transitional zone between atrial muscle and nodal tissue, right? So it's like the SA node generates the signal, and then the signal is conducted through these pathways, and then there's transitional zones between kind of like the muscle and the nodal tissue. And that also exists between, like we saw in this one, there's like the perinodal area. So there's these transitional areas, and then we also and then into the compact node. And then the compact node is gonna penetrate through that central fibrous body, which is like that fibrous part of the interventricular septum. It's gonna penetrate through it, penetrating bundle, and then it's gonna become the bundle of His, and then the Purkinje system. And then coming off of the compact node is this structure called the inferior nodal extension, and that'll be really important when we talk about the kind of the weird rings of conductive tissue. So yeah, I think that's like pretty much it. Yeah, to ventricles. I mean, that's pretty much it. I would recommend looking at some diagrams, or not diagrams, some pictures of hearts, to kind of get an understanding of what we're looking at, what area we're looking at. And so this, you can see this inferior nodal extension is kind of tracking along the tricuspid valve. But yeah. All right, moving on. So why are these areas conductive versus, like, what's the difference between conductive tissue and working myocardium? So here, got some diagrams. Maybe you already have known about this. It's just like, this is like, I would say, pretty simple physiology of the heart. So here we're looking at the working myocardium. We see this really flat, resting potential, and then we see huge sodium channels open, massive signal increase, huge depolarization, and then there's, it happens, right? Action potential right here. And then you see this transient outflow of potassium, which is blue, and it's happening the entire time, right? Like, this transient outward flow of potassium is occurring the entire time. Like, it doesn't just stop right here, but what's happening is there's an inflow of calcium channels. So what that does is that kind of maintains the membrane potential of the working myocardium at that level. So we have an outflow of positive potassium, but we also have an inflow of positive calcium. So what that does is that maintains the action potential at this level, which allows the ventricle to, in the orange, contract, and then just hold for a second to make sure all the blood gets out, and then it can release once the calcium channels inactivate. So it's like tracking this. It contracts, and then the repolarization starts, but then it's kind of halted by the calcium, which pauses it, where it's contracting. Still, it's just holding that contraction, and then the calcium stops, so then it's able to finally continue that repolarization. However, when we look at the nodal tissues, the story's a little different. We have this thing called the funny current, or the pacemaking current. I'm going to call it the funny current. It's funny. But what do we see different here? What's the main difference that we see? Well, look at this line right here. If we think of this as kind of that like potential line, what do we see? Here we see, spoilers. Here we see just straight resting potential, but we don't see that here at all. We don't see a resting potential. In everything that you talk about with neurons and with muscles and cardiomyocytes, there's a resting potential, and then a stimulus causes voltage-gated ion channels to open, which causes the signal. But in a nodal tissue, you don't have, we'll start here, because then we can see kind of the whole track of the current, but you don't have this, the resting potential. The signal happens, the contraction happens, the signal is sent, and then you see the inflow of potassium, same as the working myocyte, right? Over here, inflow of potassium. You see this inflow to repolarize the cell. Then as you get to this level right here, this, around negative 80 millivolts, this actually signals sodium channels to open. So what that does is that allows the cell to slowly depolarize. So there's this site of slow depolarization in the conductive cell, right? So there's a slow depolarization by itself. So it's like there isn't a stimulus, it's just you reach this point of repolarization where the cell gets to a low enough membrane potential and it opens up other channels. So once it opens up other channels, then they start letting in ions, which allow it to slowly increase. And then it gets to this point where the calcium channels open, and then it blasts up and has its action potential. And then potassium's let in, it repolarizes to a point, but then other channels open, and then it's allowed to depolarize during diastole. It depolarizes, and then you get this slow increase, and then it goes again. So it doesn't need another. That's why it's funny. It doesn't have a resting potential. It doesn't need stimulus. It does it itself. It's got this funny little thing where it just kind of gets to a low enough point and then starts it up again. And then boom, and then repolarizes and then gets to this point where it can just open channels and start it up again. So that's how it's generating its own action potential. It's just reaching this point, right, over and over and over, rather than nothing, signal sent, boom, right? Nothing, signal sent, boom. It's boom, and then channels open, which turn it around, boom, channels open, which turn it around. All right, so real quick, we can look at these pictures. These images are from a different paper. These show some real anatomy that we can look at to kind of put this diagram into the context of some real anatomy. So again, slow pathway, fast pathway, we got that. So here we can see this diagram is kind of showing, here would be some pectinate muscle, coronary sinus, again looking into that right atrium. Here's that fossa ovalis. And then we have the tricuspid valve, and then the right ventricle would be down here. And then that triangle of Koch, here would be kind of that tendon of Todaro. And then we would see that triangle forming. So here is kind of along that wall, that atrial septum would be the fast pathway. And then you would see that slow pathway would be coming all the way down here. And then this kind of area is where that AV node would be. And then here you can see it over here. You can see coronary sinus, triangle of Koch, anyways. Here's that trabeculate carne of the ventricle. So we know ventricle, atrium, and then tricuspid valve. And then here we can see these are those inferior nodal extensions. We'll talk about those more, and we'll talk about this paper a bit more when we get to those kind of specialized rings that I touched on in the plans. But really, these, in the scope of real anatomy, these are what we're talking about. This triangle that forms with kind of the base of the triangle being the coronary sinus, and then you have that kind of the vestibule of the tricuspid, and then the tendon of Todaro forming that triangle of Koch. We'll see what I choose for the rest of the video. But yeah, triangle, and then right at that base, and then it would be kind of penetrating into there. But here's AV node. This would be like compact node, inferior nodal extension, that kind of thing. All right, so now moving on to look at a different diagram. We're going to look at kind of the reasons of that difference in potential. So here, again, this is from this paper. Just making sure. So we have this diagram which kind of overlays atrial muscle versus the SA node. And we could see that difference, right? We have an atrial muscle with a resting potential and an SA node cell with a pacemaker potential, right? And so this is done by so the pacemaker potential comes from a slow influx of sodium, okay? And that slow influx of sodium is primarily attributed to this HCN family of ion channels. So these are all kind of in like rabbits, but these are essentially just ion channels. So sodium channel, potassium channel. CX43 is the really, really big calcium channel. And then HCN, like the family of HCN channels, are the kind of like the funny current pacemaking ion channels, right? So these are hyperpolarization activated cyclic nucleotide gated channels. So hyperpolarization activated cyclic nucleotide gated channels. All right, so back to talking about this. So in the pacemaking cells, there's a very low abundance of this KIR 2.1, right? Basically just a potassium ion channel. So this potassium ion channel is responsible for this resting potential. So we can see as that potassium, this K21 ion channel decreases, we have closer and closer to the SA node tissue, right? So less and less ability to maintain this resting potential, and higher and higher abundance of this HCN, or like the funny current ion channel. So what that basically is showing is that the ion channels are responsible for the difference in behavior of these cells. The ion channel is responsible for the difference in behavior. The expression of the ion channels change the functions of the cells, which kind of makes sense, right? So HCN, funny current, higher in the SA node, lower in like that paranodal area, almost zero in atrial muscle. Big, huge calcium channels, very low in the nodal extensions and the compact nodes of the AV node, but then it gets higher and higher as we reach the ventricular muscle. So this, again, it's the ion channels, right? What does the AV node do? It slows the signal to allow all the blood from the atria to get into the ventricles before the ventricles contract, right? So signal sent from the SA node, it slows at the AV node, and then it's sent fast, really, really fast. It speeds up until it's like almost everything at the same time at the ventricular muscle. So same thing here, right? If CX43, I think it's CBOX43 is like the proper way to say it. If this is a huge calcium channel, we see a lot of in the atrial muscle. Everything just get it into the ventricle, right? Everything contract, get into the ventricle. But then we see really low amount in the nodal extension, right? That inferior nodal extension. We see a little bit more in the compact node. We see more in the bundle of His. And then we see the most in the muscle, right? That pure working myocardium has the most of that big, huge calcium channel. So you can literally see, like, if CBOX43, let's call it, is a big calcium channel, like big, you're like big, huge ability to get the signal from your friends, then you can just see this increase in the connection of the transmitting of calcium, right? Which would cause an increase of the speed. So you can see how that signal would be slowed, faster, and then immediate, right? Like the quickest possible would be in that pure muscle. And this also kind of explains why we have the slow pathway and a fast pathway, right? If that, looking at this real quick, right? Try to keep this in mind. High in the atrial muscle, low in the nodal extension. Going back, if this fast pathway is going through the atrial muscle to get to this compact node, it's going through atrial muscle. That signal is going to be transmitted through atrial muscle fast. Then it'll reach the transitional zone and then go into the connective or the conductive tissue. If this slow pathway has to come through the atrial muscle, but then go through the inferior nodal extension, what does it have to hit? It has to hit this area of low expression of these big calcium channels. Low expression of big calcium channels means slowly getting that signal through the cells, right? It's not going to be like wham, a bunch of calcium. It's going to be like slower, smaller channels conducting that signal down. So that slow pathway has to go through this inferior nodal extension before the compact node. So that kind of explains like why is the slow pathway slow? Well, because it has to go through this area with a very low amount of these big, huge calcium channels. Once again, we have, kind of the same trend of big sodium channels. Medium in the atrial muscle, very high in the ventricular muscle. Lower, a little bit more, and then very high. It's kind of like that same trend, right? Same thing here. The K21 is responsible for maintaining resting potential, so we see that trend of increasing as we get towards just muscle. It'd be the same for ventricular muscle, right? So that's kind of, it's a big thing to think about. You can go super into depth on this, but really remember that why are the conduction cells different than the working myocardium? Well, it's the ion channels. How are signals sent from any cell? How is any stimulus or action potential sent? It's ion channels. it's electricity through the ion channels, right? So the ion channels explain why that ventricular tissue is wham, and why the Purkinje system gets it to wham, right? Like it's all at the same time. You don't want like you don't want like the apex of the heart to be contracting. Like if we have, looking at this, right? If we have the bottom of the bundle branches right here and they radiate out, you don't want this to contract and then slowly contract and then slowly. You want everything to just right? So you have these big, huge calcium channels by the time you're at the ventricular muscle. And by the time you're at the bundle of His and the Purkinje system, you have these big, huge calcium channels to really just wham that conduction out, right? But in that nodal extension, the compact node, it's way slower to slow the signal. All right, so now we can touch on the His-Purkinje system. We won't be talking about it too much. This is kind of the extent of what we'll be saying regarding the His-Purkinje system, but it is important, and it's part of the conduction system, right? So let's talk about it. So what is the Purkinje system? Well, we know the Purkinje system is that kind of the end of the conduction pathway right before the ventricular muscle. And what do we want to be happening at the Purkinje system? Well, we want simultaneous contraction of the ventricle, right? We want that signal to be slowed at the AV node, and then as it goes down His bundle branches, and then Purkinje system, we want it to be speeding up and up and up and up until hopefully we can get the signal to all the ventricular muscle at the same time so it all contracts together, right? So that's kind of what we're going for with the Purkinje system, is really, really fast conduction. So talking about that, what is dV divided by dt when talking about action potentials? Well, it's the derivative of the velocity relative to the time. What that essentially means is we're looking at a rate of change of the membrane potential over time. So when looking at these graphs, I'm going to hold up my notes so we can look at it and I can say the right thing. We really want to be important to understand that dV divided by dt is essentially the upstroke velocity. So it's the velocity of going from here to here, right? That upstroke, it's how fast that happens. And when dV divided by dt is high, that means the upstroke velocity is high. With that, we also have the amplitude of the action potential velocity. So looking at this graph right here, this is kind of what I'm pointing at this whole time. PF is going to be Purkinje fiber, VM, ventricular muscle. So we see a much higher, a quicker upstroke velocity, right? This is kind of like a softer curve versus a much steeper curve. Faster upstroke velocity, and we see a higher amplitude coming from the same resting potential, higher amplitude than that ventricular muscle. With that, we have normally, so it's not exactly this equals this, but with a higher dV, I think for instead of dV divided by dt, I'll just keep saying upstroke velocity because that's essentially what it is. But with the higher upstroke velocity, you usually have a higher amplitude, but it's not exactly like a causation. It's just usually they're tied together. And then lastly, in terms of action potentials and like the factors to think about is the action potential velocity. And so that is really, with a neuron, it's that the speed at which the action potential is traveling down the axon. So with a cell, it's essentially the speed at which that action potential is traveling, right? So with an increase in upstroke velocity comes an increase in the action potential velocity, which makes sense, right? But one really surprising thing to note is that, we would think, what do we want to be the fastest thing that contracts? Well, if we want all of the ventricular muscle to contract together, I would think that the ventricle would be the fastest contraction, right? The biggest connection channels, biggest things to be all worked into one thing and just boom. But what we see is that the action potential velocity of a ventricular muscle is around 0.75 meters per second, whereas the action potential velocity of the Purkinje fibers is actually 2.3 meters per second. So, almost like over 3 times as fast, or 3 times faster than the ventricular muscle. So that Purkinje fiber system is conducting the signal way faster than the ventricular muscle. And what does that due to? Well, I mean, we know what it's due to, right? We've talked about this. It's the ionic channels, right? Purkinje system has huge calcium channels and huge sodium channels. It's like the C-box 43 and the Na, the 1.5 current of the sodium, right? It's these huge calcium and sodium channels that allow the system to just transmit the signal everywhere as fast as possible. It's these huge ion channels. The ion channels are massive for determining the function, right? It's like, that's everything. So with that, what do we see in heart block? Well, heart block normally happens, well, if we're talking heart block, we're probably talking about the bundle branches. Again, these will all be referenced. I'm not just like saying this, but the right bundle branch has been said to be when there's a block. It's usually asymptomatic, but the left bundle branch block, that is extremely symptomatic and usually leads to or is associated with left ventricular dysfunction. So what happens in the heart block? Well, what do we think? What's a block of the heart? Well, I mean, what's doing the signaling? You know, I've been talking about the whole time. What are we talking about here? What do you think? I'm waiting. Ion channels. It's the ion channels. It's everything's the ion channels. So in the heart block of a dog, it was seen that there was a decrease in the upstroke velocity, or the dV divided by dt. There's a decrease in that. And what was that from? Well, likely a deregulation of the big sodium channels. Also, we saw a decrease in the conduction velocity. And what would that be caused by? Well, if there's a decrease in the upstroke velocity in the dV divided by dt, well then that's going to accompany a downturn in the conduction velocity. We also see a downregulation of that C-box 43, or that massive calcium channel. So we're seeing a downregulation of these massive ion channels, which means it's just not able to conduct the signal anymore. It's not as good at transmitting the signal as it used to be if these massive ion channels are being downregulated. If they're not being expressed anymore, we're not going to see conduction work as well as it did. With that, in looking at heart failure in rabbits, it was seen that, again, what do we think we saw when there was heart failure? Well, remodeling of the ion channels. Widespread remodeling of the ion channels was seen in rabbits with heart failure. I mean, it's the ion channels. Everything is like all the function of these cells is the ion channels and what it expresses. Why does it have the funny current and create its own stimulus and create its own action potential? The ion channels. It's got the HCN family. Why is it conducting really fast? The ion channels. It's got huge calcium, huge sodium channels. Why does the AV node slow the signal at that moment and then it speeds up again? The ion channels. It's all the ion channels. All right, so moving on. Time to talk about the development of the heart. I mean, why are we talking about the development? Well, we've talked about the anatomy of the heart. We've talked about some of the physiology of the different types of cells. We talked about why certain cells act differently, how they do their function. And what is that from? Ion channels, right? You're probably getting annoyed at how much I'm saying ion channels, but all the function is the ion channels. But where does that all come from? Well, the development, right? There's kind of the idea that ontology recapitulates phylogeny. So kind of like the development of an organism follows evolutionary development. I mean, that's like not necessarily true for a lot of things, but with the heart, because it has to be working the entire time that the organism's alive, it does kind of follow that idea. So we're starting later on in the development of the heart, or the organism really, because there is, before this, it's kind of like two tubes and then they come together. So we're going to start once it's one tube. So an important thing to note while we're talking about this is that, so you're going to hear the term primary myocardium, and the primary myocardium is referring to the myocardium of this original tube. Okay, so the heart's going to grow and develop, and it's going to grow working myocardium, which is like the muscle, but the primary myocardium is going to be the original myocardium from this original tube. So that's an important thing to remember, is that primary myocardium came from the primary one tube. Working myocardium is going to be muscle. And so what we'll see is that the conduction system of the heart really comes from this primary myocardium. So what do we see in this original tube? Well, we see the structure called the sinus venosus, and then the truncus arteriosus. So we're going to know venous blood coming in through here, and then oxygenated blood out here. So from the body and out to the body. Again, it's just a tube, right? So it's just going to be doing like a peristaltic motion, just like any artery or digestive tube or anything like that. Just doing a peristaltic motion, moving through with just a wave of contraction. So what we're going to see is these two tubes that I talked about come together around the 3rd week of development. And around this 3rd week of development, we're going to see an increase in the strength of this tube and the heart rate. So we're going to see as the fusion continues, we're going to see an increase of those things. And so the pulse of this primary myocardium is going to arise as in each major division as they kind of come into the tube, right? So as they create their own structure, that's when the pulse is going to arise. So what happens first is the ventricle kind of arises, and it's going to have an intrinsic rate of around 25 beats per minute. And then the atrium are going to come together, or the two tubes are going to come together to form this atrium, and that is going to start having its own kind of intrinsic rate, and that's going to be around 60 beats per minute, right? So atrium, where's my mouse? Right here. This atrium is going to be 60 beats per minute, sending a signal. This ventricle is going to be 25 beats per minute. So what happens? Well, who cares about the 25 beats per minute intrinsically sent by the ventricle? It's just going to be overridden by the 60 beats per minute of the atrium. And what's kind of that, healthy heart rate in an adult? It's 60 to 100 beats per minute. So this is kind of where that pacemaking begins to come from, is that the atrium is just sending a faster intrinsic rate than the ventricle. So it's just going to send more, like the overriding signal and control the pacemaking. And so what we're going to see is essentially a gradient of speed of intrinsic rate is going to be fastest at the sinus venosus and then slowing down into the truncus arteriosus. So the sinus venosus is sending a faster signal than the atrium, which is sending a faster signal than the ventricle, which sends a faster signal than these kind of like main artery parts of this original tube. Okay, so what do we see? Well, moving on, we're going to see that as the original tube begins to develop, it's going to essentially fold over itself, making the atria on top and the ventricle on the bottom, right? So we can see this folding right here kind of occur, right? Look at my mouse. Folding occurs, causing, and then the ventricle kind of swoops down and up, right? And then what that leads to eventually is kind of this atria that's sitting on top, and then the ventricles that are down below. Atria that appears up top, and then ventricles down below, which leads to this. So there's this folding. So I like to kind of do it with my hands, and I like to think like venous and then artery, right? So it's folding like this. And then you kind of sit on top, but you're still kind of going down. So it's kind of like that, right? You guys are going to have to stick with me here. Hold up. Let me make it bigger. Okay. Stick with me here. Okay, so I got this, right? Artery, venous is blue, right? So it divides, and it kind of goes like this, right? So we see the ventricles pumping out here, but then we see the atria like on top, right? So we see like that type of folding. If we're looking from the side, it goes like that, where you see the atria kind of end up top, but it's still getting stuff from down here, and the ventricle is lower, but it's still pumping out up, right? So it's like, does that make sense? It's like, I don't know, doing it with my hands really helps, like that kind of. I think that helps. Okay, so back to the PowerPoint. What do we see on the inside of the heart? Well, we see, if we're looking, if this is the section that we're taking right here, we're looking kind of down at the tube, right? So we're going to see a hole for the atria, like one atria, and we're going to see this little atrioventricular canal, and then the two ventricle, or, well, one ventricle, but you can see this kind of structure beginning to come up. So it's one ventricle, but we do start to see a separation. And then as we move on, we do see these two right here. And then as we move on, later on, we see that they're, again, taking section right here, but we see a little bit of the separation between the actual atria and then the sinus venosus, which looks a little bit more familiar, right? And then taking a section, we'll see some more defined openings into the atria, which have the septum forming to separate them. And then we also have these endocardial cushions, these lateral cushions, and then an endocardial cushion that are essentially developing in and like through to basically form the septa, right? And then these endocardial cushions right here that develop from that wall are what become the valves. So we have, right here, we have, kind of pushing in from the side. And then that endocardial cushion is pushing outwards to kind of link up with the lateral cushions and form a valve. So that is what we're going to see with the formation of these valves. So remember about the cushions. The cushions are what form the valves. It's these structures that come in from the side right here, and then from kind of the middle, right? Like it would be coming in this plane versus like through my mouse would be the lateral cushions, but the endocardial cushion would be coming this plane. It would be joining up and forming the valve. Okay, so we have a basic understanding of the development of the heart. We're getting there. We kind of understand it, right? It's just folding. And then we have some things that develop, okay? But now we're going to begin to look at, we're going to look more into the development of the heart relating to the conduction system. And we're going to talk about those rings that I mentioned, the weird, mysterious rings. So next, a little basic thing is the atrioventricular conduction axis. You'll hear that a lot. What is the atrioventricular conduction axis? So the atrioventricular conduction axis is essentially just the axis responsible for conduction, like atrioventricular conduction, right? It's what would that be? Correct. The AV node and the His-Purkinje system. So it's essentially just the electrical continuity between the atrium or the atria and the ventricles. Atria and ventricles. So here, I thought this was kind of interesting. Just remembering that we kind of have, colors, right? Look at the colors. We have the folding, so they kind of switch sides, but pink is the atria right here. Then we have this purple atrioventricular canal, and then the orange ventricles, and you can see the purple right here. So you can kind of understand like this axis of conduction between the atrium to the ventricle, right? So this says the AV node or AV canal / node maintains electrical continuity between chambers. So you're gonna, I don't know exactly why it's used, but you're gonna hear it used a lot as like the atrioventricular conduction axis. What is it? It's just the conduction that joins the atria to the ventricles. That's all it is. Moving on, time to talk about the rings. So what are we looking at here? So this is a paper from Yanni et al. So basically, this is like mystifying, right? They used histological techniques essentially and saw that, kind of what we talked about, like ion channels, things like that, in order to see, what tissues are specialized and conductive, right? So they did that, and what did they find? Well, here we have the AV node, right, and then the penetrating bundle, and then the right bundle branch, and the left bundle branch, okay? Orienting, this is like a coronal cut. We can see all the valves. It's above the valves, right? This is kind of weird because like superior would be like this way, like above like this way through the screen, and inferior would be through the screen. I guess that's what it means. Pulmonary protects, anterior, posterior. Yeah, right and left. So again, we're above the valves, right? We see the cusps, so we're going to be sitting above. We're not entering the valve, or we're not like entering the ventricle. We're kind of sitting above them, right? So what do we see? We see AV node, penetrating bundle, right bundle branch, left bundle branch. Then we have this aortic ring or dead end tract, as you might hear it called. But then remember those inferior nodal extensions that we talked about? Well, here we can see them. These are the inferior nodal extensions. We have these weird this wrapping of the inferior nodal extension. It came right off of the AV node. It's coming right off of the AV node, and it's wrapping around the mitral valve and wrapping around the tricuspid valve, and they come together into this superiorly located retroaortic node. So I mean, why is this here, right? Like, why is it that we have these loops of conductive tissue wrapping around the valves? Like, what does this do? I mean, what what in the world, right? Like, why is there extra stuff? Like, you're not going to see this in an anatomy textbook. This is recognized in 2009, and we're just now figuring out. We're going to talk about a paper from 2021, but we're just now figuring out like not necessarily why, but how they get there through development, which is what we're going to talk about after this. But we still don't really necessarily know why. I mean, why? Like, what is the function of these nodal extensions essentially wrapping around and then forming another node, a retroaortic node, like, retro behind the aorta, and it's a node, right? Like, why is it that you have conductive tissue wrapping around the valves? So I think I'll wait to talk about it until we finish the conversation of how they get here, but it's essentially just we're not sure. Like, there's Wolff-Parkinson-White syndrome is a syndrome where there's signaling that is basically ectopic signaling that is sent from like areas around the mitral tricuspid valve, and that's a pathology, right? It's like these rings potentially being pathogenic and sending ectopic signals. So that's it's a pathology, but why are they here? Yeah, so I think we can move on, but really remember this diagram. Come back to it while we're talking about it. This was 2009, so we're going to move on to 2021, where we know a little bit more. But really just, what do these rings come from? They come from the inferior nodal extension. So the inferior nodal extensions, the left and the right ones, they extend out and wrap around the valves and then come together into a retroaortic node. All right, before we actually move on, I wanted to touch on a couple things. I'm moving my mic around, so I think this is the right spot because it's too loud if it's down here and too quiet up here. So anyways, I just wanted to really make sure it's understood that these structures, the tricuspid ring and the mitral ring and the retroaortic node, these are not things that disappear. They're not like, the fact that they're here is not a mistake, right? Like Wolff-Parkinson-White syndrome, that is not something that goes wrong in development that causes the rings to still be there. Okay, so they're there no matter what. But with Wolff-Parkinson-White syndrome, they're just pathogenic. But they're here in the adult heart, right? Like, these are real structures. So the inferior nodal extension will make these pathways. It's not like a pathogenic thing that they're there. I just want to make sure that's understood, right? Like Wolff-Parkinson-White syndrome is not the fact that they're there. It's the fact that they're pathogenic and create signaling, but no matter what, they're there. They're consistently there, which really is what begs the question of why. And another thing is I wanted to use this. If you haven't seen this view of the heart before, it's basically like a cut, like right through here, like right there, and then you kind of like peel this off the top, and then you would be looking in. So slice right there on that coronal plane. Yeah, coronal plane right there. Slice it, open it up, and then you're looking in from the top. So that's why like inferior would be this way, superior that way. Okay, time to move on. This is where boys become men. This paper is extremely difficult to understand, but I think we can work through it. So what are we looking at? So this is going to be a paper from 2021 that's discussing the importance of those inferior nodal extensions. We saw that the rings come from the inferior nodal extensions, so that's the money, right? So we're going to look at those. So what are we looking at here? Well, here we're looking at hearts around the 4th and 5th week of development. We would see an atria, like, you know, kind of a primitive atria right here, okay? That's like removed, and then we would have that atrioventricular canal coming in here, and then you would go left ventricle, right ventricle, and then to the outflow tract, okay? So again, atria would be right here. If we go back, right, that's kind of what we're looking at, okay? But instead, these have been removed, okay? So again, atria have been removed, but we see this canal, the atrioventricular canal, and then we have the left ventricle into the right ventricle. So all blood, this shows us that all blood must go from the atria to the atrioventricular canal to the left ventricle and then the right ventricle and then out. It always has to go there. What else do we see? Well, we see here, this is going to be the inner heart curvature. Going back again, that's kind of like this curvature right here. It's going to be like, oh, geez, wrong way. It's just like where that myocardium is bending the most is the inner heart curvature. And then looking over here, Carnegie stages are essentially just stages of development that have been defined. So we now see the blue is going to be the cavity. So instead of being the actual tissue, it's going to be like the cavity of the ventricle. And we see the same atrioventricular canal myocardium, and then things would be flowing into the left ventricle, right? And then there's a developing ventricular septum. Oh my god, sorry. There's a developing septum here, but again, blood would be flowing from the atrioventricular canal, left ventricle, right ventricle, and then out. And then here we see this structure called the primary ring. So what is the primary ring? Well, the primary ring is essentially just specialized cardiomyocytes that will form the AV conduction axis. So we talked about that, right? What's the AV conduction axis? Well, it's just kind of that joining of ventricle to atria. So it makes sense that it would be on this atrioventricular canal myocardium. So that is going to be the primary ring, just specialized cardiomyocytes that form the atrioventricular conduction axis. So that's going to be really important in a bit, but let's touch on these diagrams right now. So what is going on in Carnegie stage 12? So at Carnegie stage 12, we have the atria joined through myocardium of the atrioventricular canal, right? So we have the atria joining into the ventricles through this atrioventricular canal, and then you have left ventricle, right ventricle, right? We talked about that. Now at this stage, not gonna believe this, at this stage, an adult EKG can be found. So an adult EKG, like a normal heart rhythm, can be is found at this stage of development. That's like unbelievable. But also, what does that mean? Like, what is essential in our heart rate rhythm? Well, go through the conduction system. What are the essential components, right? We have, I mean, think about it for a second. What are the essential components? What would be essential for an adult EKG? Pacemaking, something that's really fast and contracting of the ventricle, and then what's in between? A slowing, right? We need that slowing. So that means that there's an AV delay at this point. At this moment in time of development, there's an atrioventricular delay, which is unbelievable. And what does that? Well, it's going to be the atrioventricular canal. That myocardium at the canal is going to be the source of that delay, which makes sense why the primary ring, or the site at which the atrioventricular conduction axis originates, is going to be attached to that atrioventricular canal myocardium. I mean, that's like unbelievable. So there's like already beginning to be a path of preferential conduction 5 weeks in, and there's going to be a delay at this AV canal. I mean, that's like unbelievable. That's crazy. So now moving on to the Carnegie stage 14. So moving on to this area, we see the primary ring begin to form. So this primary ring is forming, right? And so the primary ring is going to be a ring of cardiomyocytes, right? We talked about that. And it's going to be encircling this developing interventricular. Well, okay. It's going to be encircling like the interventricular communication, right? So this whole area is like the communication of the left ventricle to the right ventricle. So the primary ring is going to be kind of circling that communication, and it's going to be carried on the crest of that developing ventricular septum. And it's also going to be occupying the inner heart curvature, right? So like that kind of area right here. And it's going to be separating the outflow tract from the atrioventricular canal, and it kind of puts the outflow tract specifically behind that AV canal. So we got this primary ring that's formed, right? It's going to be that, what is it? We got to get this down. Primary ring is the specialized cardiomyocytes that's going to form the AV conduction axis, okay? So what's going to happen, right? If we have an atrioventricular canal myocardium that goes into the left ventricle, and the flow is, atria to left ventricle to right ventricle, and then outflow tract, but we also have this developing ventricular septum, what do we need to do? Like, what needs to happen? Well, in our heart, we have an opening for the left ventricle and an opening for a right ventricle. So this structure is going to have to develop outwards to make a canal for the right ventricle specifically, okay? So if that ventricle is if the septum in the ventricular septum is forming, we're going to need another opening for the right ventricle. I think that makes sense, right? Like, there's just one opening, we need another one. So this is going to have to develop over to here. So that's what we see. If we move on, we can see that, again, might as well we got to orient, right? So we see this would be developing left ventricle. Here we're kind of looking down at it. We would see a developing right ventricle in this area. And same thing, it's kind of been like cut away right here. And this would be showing like the cavity of the left ventricle. Okay, so what do we see? Well, we see that necessarily that atrioventricular canal myocardium has extended outwards to make a new myocardium. That the ventricular septum has formed, right? It's beginning to arise and make, a significant septum. So we need another opening. So we have another canal that's formed into the right ventricle. But what else has happened? Well, if that tissue, if you have the primary ring right here, and you have the canal tissue right here, and the canal tissue has to stretch over, well, the primary ring is also going to stretch over with it, right? Like, if we look at here, if this tissue right here in the primary, or the atrioventricular canal, if this has to stretch over, well, this that is connected to it also is going to stretch over. So we see this ring has formed from that primary ring. So we see right here. And what do we have? Well, we have an inferior rightward extension that goes into this center area. And the center area is going to be the basis of the compact atrioventricular node. So the atrioventricular node, it's going to come from, excuse me, I'm going to flip to my notes. The atrioventricular node is going to be formed at the inferior end of the transition of the primary ring from the ventricular to the atrial masses, myocardial masses. So it's really formed at the crux of this septum, right, kind of like right here, and at the transition between this myocardium and that atrial myocardium, right? So where those two come together, that's where we're going to see, I keep on clicking my mouse, I got to stop doing that, but that's where we're going to see the compact node be formed. So I hope this makes sense in terms of why we see this kind of bulging out. You know, we need another opening for the right ventricle, and if the canal myocardium extends, then necessarily that primary ring, the specialized cardiomyocytes, are going to follow it. So that's why we begin to see the tricuspid ring, right? I mean, we see it already. It's this ring of this specialized tissue that literally makes the atrioventricular node. It makes, you know, that whole system. I mean, we already see it. It's connected. We have this rightward, you know, the inferior nodal extension that we talked about. It's just coming from this ring that forms. And then we see, remember, atrioventricular conduction axis is kind of the AV node plus the His-Purkinje system. We see that the primary ring going down to form a right bundle branch, and it's going down to form a left bundle branch. All right, so I just wanted to take a second to kind of get some bearings in case you're struggling to understand or to visualize what's going on in these like diagrams. Well, really, like, what are we looking at here? And if this doesn't really make any sense to you, well, we can look at this. Apologize, it's kind of dark, but I found this little 3D model, which I don't know why the aorta is going into. We got this nice little circulatory system aorta into the left atrium, into the left ventricle, into the aorta. Yeah, perfect. So this is perfectly accurate. Anyways, I think this would help. So with this diagram in particular, this one, what are we looking at? Well, we're seeing this kind of cutaway, and we're seeing the left ventricle and the right ventricle cutaway. So we would essentially be looking like here, right? This portion of, like, all of this has been cut away, all the atrial kind of sections, but the right ventricle would be cut away, and we'd be kind of looking at this view, right, where we see the left ventricle from this angle, right? We see it butting out, and we would looking at this, you know, if we were to slice like right there, cut all that off, then we would be looking at it from about this angle. So like that, right? I think that makes sense, like about there. And then with this one, with this side, this right panel, we'd be looking, we see left ventricle, right. So we'd be looking probably about, you know, here, but with the whole right ventricle taken away. So we're looking kind of up on, it would be like there, right? We see the septum would be like here. All of this has been cut away so that we see the left ventricle again, you know, left side, just to orient, if you're not used to looking at a heart, left, right. Towards me or towards you would be anterior, behind would be posterior. So again, if we're looking down, we would see that second panel would be about this angle, right? Looking kind of laterally from the right side and inferiorly. I think that kind of, you know, maybe a little bit like that, right? I think that would kind of make sense if I'm flashing them back and forth. Hopefully you don't have epilepsy, but I think that would make sense in terms of the orientation. I hope that helps. And also at this stage, I thought I would draw it out, but what type of like cross section are we working with? Well, now we finally have this nice, oh my god, redo that. I said, no. Oh my god. Okay, one more try. Oh, it's looking good. Yep. Ooh. Okay, we'll take it. So now we finally have this like atrium part and this ventricle part, and then we have this septum beginning to arise, and then this is where we would see, I guess I'll do this. This is where we would see like that septum beginning to form. I'll put it in yellow if that helps. We would see like that myocardium kind of being like this, and then we would see essentially like that ring would be like this and penetrating down. That's kind of what we would be looking at with that diagram. It would be like, if we were to cut into it, that's kind of what we're seeing now, especially when we move on with this. That's really what we'd be seeing. We'll be seeing this nice cross section. So we can take a look at this now, since we've talked about it. So what's going on? Really, things are kind of coming more together. Stage 23, this is near the end. The heart is going to be ending its development around week 8. So things are really coming to a close in terms of our development. But it's not done, right? We see these additional vessels or additional structures that are arising. So here we have additional changes taking place. So the atrioventricular canal myocardium is going to be sequestered. So it's going to kind of get a little bit smaller. It's going to get sequestered on the atrial aspect of the developing plane of like insulation between atria and ventricle. So you have ventricular myocardial mass, ventricular myocardial mass, atrial myocardial mass, and then like a plane of insulation, right? So the myocardium is going to be sequestered here, and it's going to form the vestibules. So specifically like the vestibules of both the AV valves. So the only persisting myocardial connection between the two masses is the AV conduction axis. Because these are being sequestered, the only real kind of connecting area would be this primary ring that dives down. And so that AV conduction axis, once again, it comes from the primary ring. The primary ring is going to be diving down, which means that's kind of like the site at the connection, right? If this is getting smaller, there's less of a connection between the atrial muscle and the ventricular muscle because that insulation is being formed. So the only place is going to be from the AV conduction axis where they join. So the axis transitions from atria to ventricle, or like atrial components to ventricular components, by passing between the inferior margin of the endocardial cushions. So remember what we talked about, right? I told you to remember the cushions. Remember those cushions in the cross section? I can go back if it helps. These endocardial cushions. So the axis is going to be transitioning from atrial components to ventricular components by passing between the inferior margins of the endocardial cushions. Okay? So it passes between the inferior margins of the endocardial cushions. And so at the end of development, for the heart at least, so week 8, there's going to be a point of penetration of that axis, the conduction axis, and this is going to be called the cardiac crux. I don't think it's labeled, but this is essentially the cardiac crux right here, like that point of penetration, where the primary ring, as it emerges from the ventricular mass, gets overlain by a vestibular mass and a mesenchymal cap. So we're not really going to talk about like what those are, because that's more into depth than we need to go. But really, this is penetrating down and being overlain by a vestibular spine and a mesenchymal cap. So the transition from ventricular to atrial component, we talked about this already, right? What forms the AV node in terms of what we're talking about? It's the transition of ventricular to atrial components is going to make up that AV node. All right, so I think I've already said this, but I want to reiterate that. So while I said that the atrioventricular canal myocardium is sequestered on the atrial aspect of that plane of insulation, I want to reiterate that the cardiomyocytes of the primary ring surround the developing orifice of the tricuspid valve, right? If we go back, they surround the developing orifice of the tricuspid valve, which forms the basis of the compact node, and its right inferior nodal extension. Okay, these primary ring cardiomyocytes are overlaid by cardiomyocytes from the tricuspid valvar vestibule, so the vestibule, right? And the tricuspid valvar vestibule, those myocytes are derivative of the atrioventricular canal. Okay, so although the canal gets sequestered, the vestibule, the cardiomyocytes that make up the vestibule, are derivative of that atrioventricular canal myocardium, and they overlay the primary ring myocytes, and that's significant because this is just the vestibule. This means that the vestibule is another specialized area, right? Because the atrioventricular canal provides that necessary delay in conduction in many animals, along with during development in mammals, right? So we know that there's the atrioventricular canal in animals provides a delay in conduction. So that means that this is significant, right? Like this tissue that overlays the primary ring itself is significant along with the primary ring. And so what else are we going to see? Well, there's myocardium that's significant here. Where else is there myocardium? On the left ventricle and the vestibule of the mitral valve. So we also see the atrioventricular canal myocardium on top of the mitral valve. So what does this mean? Well, connect it to what we've talked about, right? Like, what do we think the significance of this atrioventricular, the atrioventricular canal myocardium being on top of the mitral valve? Well, in the adult heart, what structure that we've talked about, what structure is it going to form? Well, it's going to form this ring. The atrioventricular canal myocardium is the ring that was identified by Yanni. It's the atrioventricular canal tissue. That tissue that we know is significant, that lays itself over the valve, is the ring that's identified. So, I mean, that's insane, right? So, the second ring, right? This second ring, it provides how am I trying to say that? Like the second ring is the tissue, right? It's this whole scope of tissue. So it's really providing both the tricuspid valve vestibular myocardium and the mitral valve vestibular myocardium. And the mitral valve vestibule creates the second inferior nodal extension. So it creates that second nodal extension that goes into the AV node, right? We looked at like the extensions, right? It creates the second one. So it's the mitral valve and the atrioventricular canal sitting on top of the mitral valve on the vestibule that creates that second nodal extension, whereas the primary ring and the tricuspid valve vestibule is what makes the rightward inferior nodal extension. So going back to here, so really both of the inferior extensions of the atrioventricular node are specialized, but specifically the right one is derived from the primary ring along with this atrioventricular canal myocardium. So it's both together. You also have the primary ring tissue inside that vestibule, which in the so the primary ring is also associated with the tricuspid valve vestibule, which is derived from the ring that comes from the atrioventricular canal. I think that maybe confused somebody, so I'm going to say it again, but this side, right, it has the primary ring on the right side, on the tricuspid side. It has the primary ring, which is significant, right? It's what makes the AV node. And well, okay, the primary ring is the same cardiomyocytes that make the AV node. I want to be specific. It has the primary ring and it has the tricuspid valve vestibule. Now, the tricuspid valve vestibule is derived from the ring that comes from the atrioventricular canal. I think that made sense. So with this, either extension, either of the inferior nodal extensions can be presumed to be capable of slow conduction. Remember we talked about a slow and a fast pathway? Well, either of these extensions may be capable of slow conduction, which means that one or both of these is believed to be the potential substrate for the slow pathway. So if you think of like substrate, it's kind of like the material that it would pass through, right? So either of these extensions may be, basically either one could be a potential substrate for that slow pathway that we talked about. However, the fast pathway is going to be the septal connections of the compact node. Well, okay, for when talking about the fast pathway, where was it, right? We had the slow pathway that was really, in this area, right? And then we had the fast pathway, which was essentially a straight shot from the superior vena cava and the SA node area straight down the septum to the AV node, right? So it's going to be septal connections of the compact node are derived by a muscularization, where's my mouse? A muscularization of the vestibular spine and the mesenchymal cap. So it's going to be, basically you have the primary ring, which is like the AV node at this point, and then it's going to be a muscularization of this structure, the mesenchymal cap, and this structure, the vestibular spine. The muscularization of these structures is going to, turn it into working atrial myocytes, and these connections of the primary ring plus vestibular or mesenchymal cap and then vestibular spine on top of that, those turning into muscle, atrial working muscle, which we know has big pathways, right? Big calcium channels, big sodium channels. That muscularization is going to help to form the fast pathway. So we have nodal tissues, essentially conductive tissues that are significant, right? Significant canal tissues. We know it slows a signal. I'm like I'm saying it and it makes sense as I'm talking about it. Why would it be slow? Because the atrioventricular canal is what slows the signal, right? In many animals, the atrioventricular canal slows the signal. They have a simple heart, so that is what slows the signal. So if you have a pathway of atrioventricular canal myocardium, that's going to slow the signal. That's going to form a slow pathway. If you have a pathway of cells coming from, here's the node, right? And then all of this turns into muscle, and you just have node and then muscle to the next node, that's going to be fast. I mean, it makes so much sense, right? Like, you have atrioventricular canal tissue. Here's remember, little orientation. Again, here, we have the vestibule would be this area, the septal vestibule. So if it's overlaid with atrioventricular canal tissue, what does the atrioventricular canal do? It slows the signal. So if it's overlaid, it's going to be a slow pathway. If we have a muscularization of the septum, right? AV node right here, and then the septum, and if all this becomes muscle, you're going to have muscular connections, which are very fast, huge channels that they're going to take that signal really quickly down, forming a fast pathway and a slow pathway. I'm giddy. It makes so much sense. It makes so much sense. It's like unbelievable. It makes so much sense why it's not just like the distance of the slow pathway versus the fast pathway. I mean, that's kind of how I explained it at the beginning, but it's more than that. It's about the tissues that form the slow and the fast pathway. I mean, this is like amazing. So I think one question you may be wondering is, we've talked about this one, right? Do I need to say it again? Primary ring plus the atrioventricular canal tissue, and then we have atrioventricular canal tissue, these two rings. But what about this guy? What is this again? Retroaortic node. So what about the retroaortic node? What forms that? So where does the retroaortic node come from? What causes this to exist? Why is it a node where these rings come together? Well, we talked about the compact node. How does the compact node form? Well, the compact node forms at the inferior end of the transition of the primary ring from the ventricle to the atrial myocardial masses, right? So as the ventricle and the atria, their myocardiums come together, the compact node forms at the inferior end of the transition, right? So the compact node, how can I say this in a way that makes it a little bit easier? Compact node forms, so there's a transition of the primary ring from the ventricle to the atrium, right? There's a transition of that primary ring. Now, if you have, wish I had another hand. Let's say like this is atria, this is ventricle, right? If my hand like this is the ring, then at the lower end down here, that inferior end, that's where the compact node is going to form. But there's also this superior end, okay? So during development, there's a second transitional part, which is that superior end. But this superior end is broken and separated by the ongoing development, or during development, with the formation of a fibrous continuity between the aortic valve and the mitral valve. So if we look, I've got a couple pictures here. So right here, what's asterisk? It's this fibrous part between the mitral valve and the aortic valve, right? So again, you can see this, it's called the aortomitral continuity. But it's essentially where there's this mitral valve and the aortic valve, specifically the non-coronary cusp. But these come together to form a fibrous continuity, right? And you can even see, this is actually a pretty nice diagram because it shows where the central fibrous body is, where the left bundle branch is, and where that transition would be going, but it stopped by the fibrous part. So you have, so here, looking at this picture, you have, it's actually muscular. So in this paper, they talked about hypertrophic cardiomyopathy. And so in hypertrophic cardiomyopathy, it's actually muscular. But then in a normal heart, you would see this fibrous aortomitral or mitro-aorto continuity, right? Here, looking at an echo, you have left ventricle, left atrium. This would be the aorta. Here's where you would see that fibrous continuity between the non-coronary cusp of the aortic valve and the mitral valve, or like the aortic leaflet of the mitral valve. So essentially, I think, I don't know, it was hard for me to visualize that fibrous continuity, so I wanted to include a bunch of pictures. But the formation of the fibrous continuity means that the myocardium that was there is essentially, like, it disappears, right? It becomes fibrous instead of muscular. So this process actually basically reduces the myocardium of the inner heart curvature. So if we go back to, let's go with like this one, I guess. Like we have left ventricle, you would see basically like this inner heart curvature would become less myocardium, more fibrous. But if we have an inferior transition and a superior transition, and the superior transition is kind of broken off and it's not connected anymore, well, you still have this atrial remnant of the second transition of that primary ring. So I hope that makes sense, but it's basically like, I don't think I need to go over it again, but I feel like I should. The compact node is formed as, basically there's a transition of the primary ring from the ventricle to the atrium, right? And the compact node forms in the lower part. The superior part is broken off by the fibrous body, but there's still this atrial remnant from that superior transition. That atrial remnant of the superior transition of the primary ring is what forms the retroaortic node. And it's separate from the compact node by an area of working myocardium. So you get this separation, and now there's just working myocardium instead of like primary ring tissue. It's separated, and there's now working myocardium, but that's basically blocking the pathway. You have like the fibrous continuity and the working myocardium that's blocking the pathway between the retroaortic node and the compact node. So what's the function of the retroaortic node? Well, we don't know. I mean, it's unknown, right? Like, we don't exactly know a function of, I guess I'll go back to this. We don't really know a function of these rings. We don't really know, like, we know why they're there, right? I guess we know how they're there, but we don't exactly know why. We know that these ones could form essentially a substrate for the slow pathway, but we don't exactly know what the significance of the joining and the retroaortic node is. So we know that the rings can form a substrate for the slow pathway. We don't know why or what happens where they come together into the retroaortic node. Okay, so now that we've talked about retroaortic node, we talked about how these structures form, we looked at all these diagrams, we kind of understand a lot more about the slow and fast pathway of the atrioventricular node. So now let's go into depth on the AV node, and let's talk about atrioventricular nodal re-entry tachycardia. So for this, let's go to paint. I can draw it out. Oh my god, this is horrible. All right, so what's going on in atrial nodal re-entry, or atrioventricular nodal re-entry tachycardia? So we have essentially, we have the atria is going to send signals, and then we're going to draw it like this. So, boom, and boom. Okay. And boom. Okay, so this is going to be the slow pathway. There we go, slow. This is going to be the fast pathway. So, and then let's do A and B. All right, so what do we have here? So we have the atria is going to be sending signals this way, right? It's going to be sending signals down, and then the signals are going to travel down the slow pathway and the fast pathway, and then they're going to be sent out through the ventricle, or to the ventricle, really. So what we have here is, let's draw this as the AV node. AV node. Okay, so one thing about the slow pathway is that it has a very, well, actually, before we get to that, so signal comes down, and what's going to happen? Well, it's going to split. So the signal's going to split. It's just going to go to whatever conductive system or conductive tissue that it can go to, right? It's not partial, so it's going to come down the slow pathway, and it's going to be kind of like this, right? It's going to go slow. We already know why it's slow, but it's going to go real slow, okay? But it's going to go a lot quicker down the fast pathway. So it's the fast pathway is essentially going to beat it to the point in which it sends to the ventricle. So the fast pathway is going to send its signal down, okay? And then that signal is going to continue around, and then it's going to hit right here. It's going to hit. And then this is going to stop the signal, right? This signal is traveling around, and it's going to hit right here, and it's going to stop. So it stops, and then that's it, okay? So then everything's just blank. The signal's been sent down to the ventricle, and that's it. So now, what happens with atrioventricular nodal re-entry tachycardia? Well, the slow pathway actually has a very fast, or I guess like short refractory period. So I'll just write that in. Short refract. Short refract. And this is a long long refract. Yeah, let's go with that. So the slow pathway has a very short refractory period, and the fast pathway has a long refractory period. So again, we start with a signal from the atrium, or like the SA node. We'll do that as a node being sent down. Okay. And normally we have kind of this, fast pathway beats it, slow pathway gets essentially inhibited by that signal that comes and travels back around. But if essentially, okay, so if this is happening, right, we have the slow pathway that looks like this, okay, and then we have the fast pathway that looks like this, okay. So if the signal's sent, right, we have the same thing that happened last time. This is being inhibited right now. I'll draw it in red. So the fast pathway being inhibited, okay? Now, if during this time, remember what we said, the slow pathway has a short refractory period. If during this time we get another signal, like an ectopic signal, then that's going to come down, right? But it's going to hit this fast pathway. It's going to be still refracting, right? It's going to be like unable to take an action potential. But the slow pathway is going to be able to take that up because it has a short refractory period, so it's already going to be good again. So now it's going to take it, and it's going to take that signal down. So this is going to be an ectopic, a bad signal, right? It's going to take a signal down, and it's going to be good. Okay? It's going to take that signal down its slow pathway. But what's going to happen? Well, since this is traveling and it's taking its time down here, it took up the signal because it's already ready to go again. It's slowly going down. By the time it reaches right here, it sends the signal, and then it keeps going in the same way the fast pathway does. But what happens? Well, now that you've had this time, now the fast pathway has essentially lost its inhibition, right? So this is all good to go now. The fast pathway is ready to go again. So when this signal comes back around from, let me switch back to green. Okay, so when the signal is coming back around from that slow pathway, it's going to be sent down here, but it's also going to keep continuing this way, and then it's going to hit the fast pathway, which is now ready to go again. So the fast pathway is going to take that signal, it's going to go up here, and again, while this is happening, the slow pathway is in its refractory period. Fast pathway is coming up here, and then we're back at this area, and then what happens? Well, the slow pathway has a short refractory period, so it's able to send it again, and then it keeps going, and then now this is refracting, right? So now it's refracting, and then, can you see where this is going, right? You got the signal coming from this way, and then this is good again, so this takes it, and then by the time it reaches here, it sends a signal, and then it keeps going, and then now this has ended its refractory period, so it can take it again, and then follow it, and then this is good, and then it sends a signal, and then boom, sends a signal, boom, sends a signal, boom, sends a signal, boom, sends a signal. So that's why you get tachycardia. It's essentially this looping of the pathways because of like the timing of the refractory periods. I hope that made sense. I hope I didn't like fudge the explanation. I definitely recommend you could probably watch a better YouTube video about it that explains it in a better way. Just because it's a little bit harder on paint. I would like to use animations or something to make it better. But that's essentially the mechanism of atrioventricular nodal tachycardia or re-entry tachycardia. It's basically the timing of the refractory periods. The slow can pick it up, and then by the time it reaches to the bottom, it both sends the signal, but then the fast is ready to go. So it loops it, and then the slow is ready to go. Fast is refractory, sends the signal, fast is able to go again, so it's good to go. Loops, sends a signal, fast is ready to go again, and then it's just looping. And every time it loops, it sends the signal down, down, boom, 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 boom. So you get a tachycardia that's associated with this this looping, right? If this is looping around and around, every time it reaches this part, it's going to take this pathway down along. It's going to take this pathway down along with taking this pathway. So every single time that that signal like recirculates, it's going to send a signal down, which means that it's going to be sending signals way quicker than it should be. So that's why you get tachycardia, which is fast heart rate, associated with the atrioventricular nodal like reentry circuit. So the mechanism of AVNRT is really important to understand, especially for what we're about to talk about and talking about AFib later on. So if you didn't understand my explanation, I definitely recommend going and watching a YouTube video, like someone else's YouTube video. Like I think when it's animated, it's a lot easier to understand, but there's a million videos out there that explain the typical slow, fast AVNRT that we're talking about. So moving on, we're going to be looking at how the rings that we talked about play into AVNRT. So moving on, we're going to be looking at these proposed ideas, and it comes from a paper that's titled "The Specialized Atrioventricular Ring Tissues Participate in the Circuit of Atrioventricular Nodal Reentry Tachycardia." So a little bit of a spoiler. Again, everything's going to be linked at the end of the slide, so you can get it if you want. But yeah, so to begin talking about this, we see this figure right here. So what do we see? Well, for reference, we see the tricuspid valve right here. We see that septal leaflet. We see the coronary sinus. We see the fossa ovalis. So we're looking kind of through the right atrium, into the right atrium. We see, and so what is this area? Well, we've kind of talked about this. This is like the money area. This is that triangle of Koch. I looked it up. It's Koch, not Coach. So really, this is essentially their theoretical model of AVNRT. So we see the left inferior extension, which is derived from what? The atrioventricular canal myocardium, right? So this is that left inferior extension, and so it's derived from the atrioventricular canal myocardium, and it also has a low expression of the connexin 43, or that C-box 43 that we talked about. And what does that do? It's huge calcium channels, right? So just another kind of point to note on why this would be a slow area, okay? And then we also see the right inferior extension could either be slow or fast, since it incorporates both. Well, what does it incorporate? The primary ring and the atrioventricular canal myocardium. And this area is also seen to have a higher expression of that connexin 43, that big calcium channel. And so this red arrow right here, this red arrow is also, note like these little arrows, these are kind of showing like the circuit kind of potentials, right? Just looking at this diagram. But this red arrow is going to be the site of successful ablations for AVNRT. So what's ablation? Well, it's essentially burning through either radio frequency or with like really cold thing, like cryogenic, not cryogenic, but essentially just like really cold. You burn it, or you use radio frequency, but you burn a certain area of the heart tissue to stop the signal from going through there, right? If you burn it, it's going to scar up, and there's not going to be any possibility of conduction being moved through it. Okay, so that's what ablation is. So this red arrow right here, this area, which is called the septal isthmus, is going to be the site of the do you guys know how to spell that? Septal, ISTHMUS, in case you wanted to know, because it kind of sounds weird. So this septal isthmus is going to be the site of that successful ablation. So we know that we can successfully ablate the tachycardia circuit by applying radio frequency lesions, right? Making lesions with radio frequency at the septal isthmus, which is between the septal leaflet and the coronary sinus mouth, so right here. And this is going to be kind of it's going to be like the slow pathway, right? We talked about this. So we know that ablation of this area is successful for AVNRT, which is pretty big, right? So moving on, we got another picture. This is going to be, again, that money area, right? We see that septal leaflet of the tricuspid valve. we see coronary sinus, foraminal valley right here, and then we have kind of this proposed fast pathway, slow pathway, and then they're shining a light to show that it's the membranous septum. Okay, so you would have kind of the AV node right here. Okay, here's that triangle of Koch kind of right here with slow pathway, fast pathway. So what are we looking at? Well, on the left panel, we see all these things. So these lines, BB and CC, these correspond to the histological sections over on this right panel, okay? So BB, essentially, if you took this section, this would be right here. If you took CC, if you took this section, this would be right here. So what do we see in B? Well, we see this last septal input to the conduction axis prior to the fibrous, so it's white, right? This last input prior to the fibrous insulation of the atrioventricular junction, okay? So you can see the myocardium, and you can see the white is going to be that fibrous tissue. So we're going to see this last input to the conduction axis before the junction, okay? So here's that junction, last input, okay? So what else? Well, this is suggested to be the substrate of what? Okay, like you tell me. So we're right here. Okay, BB, we're taking a section right here. What is this last septal input going to be? A substrate for. Remember, substrate is like the material that, or the, yeah, like the material that something can pass through, okay? So it's going to be the substrate for the fast pathway, right? Going down that septum, take a section right here, it's going to be the substrate for the fast pathway, or suggested to be the substrate of the fast pathway. This paper is very hypothesized, but that doesn't mean it's inherently, you know, something to discount, okay? So that's why we're talking about it. Now, moving down into this section, remember we're a little bit lower now, we're looking into that slow pathway area rather than the fast pathway, okay? So what do we see? Well, we see the compact node right here, okay, right at this arrow, and we see its rightward inferior extension, okay? So, or inferior rightward extension, same thing. So in this histological section, they tracked the inferior rightward extension until it could no longer be distinguished from the vestibular myocardium. So they tracked it all the way so you couldn't really distinguish it from that vestibular myocardium. So essentially, we're just seeing these sections, and we're seeing the paths that these conductive tissues take, right? Here's the coronary sinus for reference. So you see that right at this level, right at the top, we see this section. We see the compact node right here, and then its inferior extension. Now, so what is this paper overall suggesting? Well, we saw the spoiler, right? Specialized AV ring tissues participate in the circuit of AVNRT. So what does that mean? Well, they speculate that, we'll go back to here so we can look at some of the real anatomy. Yeah, we'll go back to that. So basically, it's speculated that in patients with the typical slow-fast AVNRT, which is what kind of I described in the demonstration, it's what we've already talked about. The typical slow-fast AVNRT, the remnants of these ring tissues are short. Okay, so it suggests that the size of the ring contributes. So the size of the ring has a huge impact. So in typical slow, fast AVNRT, the ring tissues are small. Therefore, a complete circuit requires capture and excitation of a very close atrial or transitional tissue that is capable of conducting fast enough to support tachycardia, right? So if it's like a looping, really quick looping, right? It's that typical boom, 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 boom. It's going to be localized to this area, okay? With the atrial and transitional tissue, which, you know, atrial has big connections. Transitional is kind of getting in between big and slower of the AV node. So it's going to be localized to this area so that the signal can be transmitted fast enough to support a fast heart rate, right? If it has to pass through slow pathways, it's not going to be essentially fast enough to maintain a tachycardia, okay? Because even if you're getting a looping of signal, it's going to be slowly conducted, so it's not going to be fast enough to do a tachycardia, right? So it's suggested that essentially if you have the typical AVNRT, the slow-fast AVNRT, between these two pathways, then it's going to be just localized into this area because of shorter ring tissues. So there's going to be much smaller ring tissues, which means that the complete circuit is just, it has to be in this area of atrial and transitional tissue, because that is what's capable of conducting fast enough. However, in a majority of cases, the ring tissues extend to at least the septal isthmus where successful ablation occurs. So it's going to be extending-ish, to this area. This is the septal isthmus, okay, that area between the septal leaflet and the coronary mouth, or the coronary sinus mouth. So in normal cases, they extend to at least this area, which is why we see ablation being successful. Now, in atypical forms of the arrhythmia, right, like any tachycardia arrhythmia, or okay, let me slow down. Just arrhythmia in general for this type, okay? So in atypical forms with prolonged HA intervals, so what's an HA interval? Well, an HA interval is going to be the His to atrial interval. So it's going to be the amount of time between the signal being in the His bundle and the signal being in the atrial. So if that's longer, you're going to see a slower movement of that signal, right? So in atypical, because that's not kind of the normal way that we see the arrhythmia. So in atypical forms where that HA interval, well, okay, before we say that, so the HA interval, what does that suggest? Okay, so if that's longer, right? If there's a higher amount of time, a longer period between the His bundle and getting back to the atria, what does that suggest? What do you think? Well, it suggests that essentially it's involved with pathways with only what type of conductive properties? If it's a longer interval, it's going to suggest that it's involved with pathways specifically of slow conduction properties. So if there's prolonged HA intervals, the His atrial interval, in these type of atypical arrhythmias, the involved atrioventricular ring tissues are likely to be more developed and longer, thus participating in the circuit as components with slow conducting properties. So likely what causes the HA interval, the longer HA interval, is going to be a lengthening, a bigger atrioventricular ring tissue that makes it so that we see, this longer interval, okay? So essentially more tissue with slow conducting property is going to contribute to a longer HA interval. Now, this is also backed up because in these tissues, we see not only just, atrioventricular canal myocardium, but we do see a lower expression of the connexin 43. So just looking at ion channels, it's going to be a lower amount of that fast calcium channel kind of connection. So this could explain a variability in basically with tachycardia, with this type of tachycardia, there's a significant variability in the retrograde atrial activation. So retrograde kind of means like backwards. So it's going to be backwards kind of activation of the atria by a signal coming this way, okay? So this could explain that retrograde atrial activation during tachycardia, which may stimulate even the atrioventricular re-entry due to a left accessory pathway, like a left lateral accessory pathway. So some path, like it could essentially signal backwards, which would signal, which would, stimulate it and then send a signal back down, and then add another kind of re-entry signal, okay? So, and a big thing to note is that in this paper, they say that in persons with discernible ring tissues, without discernible ring tissues, so with no discernible ring tissues, no AVNRT is developed. So if there's no atrioventricular ring tissues, there's no AVNRT that develops. So I hope I didn't move too quick through that. But really, it's just like, this paper is just suggesting that the size is what's really important. If there's small ring tissues, everything's going to be localized to this area, and you're going to get fast, the typical slow, fast conduction. If there's big ring tissues, then this signal is going to be able to kind of propagate more through slow conductive tissue, which will contribute to the higher HA interval that we see in the atypical atrial AVNRT. So now moving on to the third figure in this paper, we kind of see this new proposed diagram of the AVNRT circuit. Okay, so again, same thing. We're looking into the right atrium. Here you can even see the trabecular carnate of the right ventricle versus the right atrium. This is going to be the septal leaflet of the tricuspid valve, the right atrioventricular ring, the left atrioventricular ring, and then here's that proposed circuit, right? And then here we have the coronary sinus. So depending on the development and the length of the atrioventricular ring tissues, the potential circuits, which is blue, may be contained within the triangle of Koch, right, in this area, which would be the typical slow, fast AVNRT, or extend towards the left, or especially the right vestibule of the tricuspid valve, which would slow that slow the HA interval, which is what we see. Okay, so we see in atypical, we see a longer HA interval. Okay, and this paper is suggesting that the longer HA interval is due to larger atrioventricular ring tissues, which would propagate that signal through slow tissues, which would make that interval larger compared to if there's, if it stops right here and stops right here, that circuit would be contained in this area, which is, more atrial muscle and transitional tissue, so it'd be able to propagate a lot faster, which would support a tachycardia. I think that makes sense. Might need to rewatch it a couple times. I'm not sure if I went too quickly. But yeah, I think I summed it up well at the end. Yeah, so now it's time to move on to the ganglionated plexi of the heart, which are essentially the sites of the extrinsic innervation. So what we've been talking about so far is all intrinsic innervation. Now we're going to touch on the extrinsic innervation of the heart, which is going to be the sympathetic and parasympathetic nervous system. All right, so time to start talking about the autonomic nervous system innervation of the heart. So far we've been talking a lot about the intrinsic innervation of the heart and the intrinsic neuronal pathways, right? SA node, AV node, His-Purkinje system. But with the autonomic nervous system, we're going to see an intrinsic and an extrinsic component. So when I say intrinsic and extrinsic, for this section, I'm going to be talking about the autonomic nervous system. For what we've been talking about, I'll say cardiac conduction system, but intrinsic and extrinsic are going to refer to the autonomic nervous system right now. So the autonomic nervous system has both intrinsic and extrinsic components as it innervates the heart, right? So the intrinsic component of the autonomic nervous system innervating the heart is going to be clusters of neurons known as ganglionated plexi or plexi. So these are going to be interconnected to the atria and the ventricles and to the extrinsic autonomic nervous system. So the ganglionated plexi are interconnected to the atria, ventricles, and the extrinsic autonomic nervous system innervation. So now what about, so these are going to be connected to and play a role in modulating the function of the SA node and the AV node, the intrinsic, the ganglionated plexuses. Now, what about the extrinsic? So the extrinsic component of the autonomic nervous system is going to arise from for the sympathetic system, it's going to arise from the gray matter of T1 to T6, and these sympathetic fibers are going to play a role in increasing the heart rate, increasing the contractility of the heart, and stimulating inotropy, which is the force of contraction. So this is done in the sympathetic system by noradrenaline binding to beta-1 adrenoceptors, and this is going to increase the... So where are the beta-1 adrenoceptors? Again, I'm trying to like brush past this because we really don't need to go in depth on this, but essentially the sympathetic fibers are going to innervate these beta receptors, which are found in the SA node, the AV node, and the ventricular muscle. And then when they stimulate these beta receptors, that's going to increase the permeability of sodium, which then increases the heart rate. Now, what about the parasympathetic system? Well, the parasympathetic system is going to arise from the medulla oblongata, the pons, the midbrain, and then some fibers from the S2 to S4. So kind of that parasympathetic, craniosacral, those two areas. And the parasympathetic system is going to play a role in the resting heart rate. So the resting heart rate, that tone is going to be dominated by the parasympathetic system. And it's going to, essentially the parasympathetic system is going to reduce the heart rate and slow impulses from the atria to the ventricle through a release of acetylcholine. So the release of acetylcholine is going to reduce the rate of depolarization and the force of contraction of the atria. And this also, it achieves this by reversing the sympathetic effects on ion channels and the calcium handling. So essentially, parasympathetic system is like toning down the effects of the sympathetic system and modulating the resting heart rate, whereas the sympathetic system can increase the heart rate, increase the force of contraction, stimulating inotropy, things like that. So moving on, we're going to be talking about the ganglionated plexi. So what are ganglionated plexi, where are they, and how are they significant in atrial fibrillation? So I got a couple diagrams right here, and essentially ganglionated plexi, we've already kind of said it, but ganglionated plexi are going to be the neural clusters of the intrinsic cardiac ganglia. So it's just going to be these areas of, like plexus, it's a network of the intrinsic cardiac ganglia. So these are going to be containing the local circuits, parasympathetic neurons, and sympathetic afferent and efferent neurons. So these, you can see these diagrams, but really what this is not showing is that these are all going to be found in the epicardial fat. So in that little, it's like a fat pad that kind of sits on the epicardium, also known, it's also called like the EAT, the epicardial adipose tissue. That's where these ganglionated plexi are going to be found. So, excuse me, I'm sniffly. So in this, in these diagrams, these arrows, these are indicating the direction of the impulse and the connections from the left and the right vagosympathetic trunks. So these are going to be coming down and connecting and showing the directions, right? So they're going to be showing the pathways of that innervation, the vagosympathetic, so parasympathetic and sympathetic innervation into these two areas, right? And these pathways are going to modulate the SA node and attenuate the sinus rate slowing, and they're going to influence the AV node functioning and the ventricular rate response. So we can see these two are the SA node and the AV node, but then we'll see that essentially these ganglia, or these ganglionated plexi, are just kind of connecting to these and modulating. And then here's some other views seeing from above, and we'll look at it above again. But really, overall, the ganglionated plexi can have functions like modulating sinus rhythm and shortening the atrial refractory period. So shortening atrial refractory period and modulating, increasing or decreasing the sinus rhythm. So now, what do we see? Well, where are these ganglionated plexi really located? It's the pulmonary veins. So the pulmonary veins, excuse me, the pulmonary veins are going to be the main site of these ganglionated plexi. And so there's going to be ganglionated plexi on the posterior regions of the right atrium and the left region, or right atrium and left atrium. This is kind of called like the dorso-atrial region. But really what's going to be going on is essentially a modulation. So you have the left-sided GPs and the right-sided GPs. So the left-sided are kind of going to kind of feed into the right side, and the right-sided GPs are going to be essentially modulating the effects of the stimulated left side GPs as the right side ones connect to the SA node and the AV node. So I'll just draw it out real quick. Paint. So you have like left. Actually, here, let's do this. So we have left GPs, right? And then right GPs. CC. And then these are kind of going to be like this site, right? So you have the left GPs, and then the majority of them are going to be in this area of the pulmonary veins, and then they're going to be sending the signals here, and then things are getting modulated by these right GPs. So the signals from the left GPs are going to be sending them to the right GPs, and then the right ones are going to be modulating it, and then they are going to send them to the SA node and the AV node. Oh my God. There we go, AV node. So this is kind of like the pathway, right? The right GPs play a big role in modulating that input from the left. But so back to the PowerPoint, we see a huge kind of cluster of them around those pulmonary veins, right? So what's significant is, so basically in like the morphology of the pulmonary veins, as the pulmonary veins, as the tissue from the pulmonary vein approaches the ostium of the pulmonary vein, right? Like as the vein approaches the opening, we're going to see that there's atrial tissue which kind of doubles up over its circumference. So over the circumference of the pulmonary vein, we're going to see atrial tissue doubling up over it. So that's going to form essentially a myocardial sheath of both pacemaking cardiomyocytes and just like a multi-layer sheath of muscle, like myocardium, right? So pacemaking and just normal myocardium is going to essentially encase that opening of the pulmonary vein. So why is this important? Well, this essentially says that there's tissue of atria encompassing this, and then we have all these ganglionated plexi around it. So there's going to be this association where basically these bundles of different neural clusters, right? These clusters of neurons are going to associate with each other, and you're just going to get a mesh-like just area of neurons, okay? So the areas around the pulmonary veins are just going to be these, abundantly enriched areas filled with sympathetic, parasympathetic, and pacemaking sites. Right around the pulmonary veins, it's this whole area here, around here, around here. This is all just basically filled with pacemaking, or not pacemaking, but sympathetic, parasympathetic, and pacemaking innervation. So what this means is that in practice, the areas around the pulmonary veins can essentially fire at random and induce atrial depolarization. So electrical discharge can just come from any, the area around these pulmonary veins can just generate electrical discharge, and that can be from the ganglionated plexi or the pacemaking areas. It's really just this site of intense ability to generate electrical signals, which is really important. So moving forward, here's another image looking down on the heart. We see, if this is going to be the left side, this is going to be the right side, posterior, anterior, the aorta, pulmonary artery. So we're seeing that here's where those ganglionated plexi are going to be, okay? And we see all over the pulmonary veins and all in this area. Really, I mean, they're just everywhere on this dorsal side of the heart or posterior side of the heart. So what does this mean? Well, ganglionated plexi actually play a huge role in AFib, okay? So the active area of ganglionated plexi sites, or the area where the vagal response is mostly elicited, appears significantly higher in AFib. So there's a higher area of active ganglionated plexi during AFib. When there's AFib, there's more ganglionated plexi activation. What that means is that ablation of the ganglionated plexi leads to a decrease in AFib. That's huge. So ganglionated plexi play a massive role in AFib through just overstimulating these areas with sympathetic input or parasympathetic input, right? It's just kind of blasting, that's why these areas, or that's one of the reasons why these areas are arrhythmogenic, is because there's this huge area of, huge area of innervation right here. So this area becomes really important in trying to understand how to fix AFib. So, like I said, ablation of the GPs leads to a decrease in AFib. So what are we going to do? Well, where should we ablate? We're going to ablate around here, right? Isolate those pulmonary veins. And that's going to be, traditionally that's like the first step in AFib is pulmonary vein isolation. So moving on, we're going to look at a maze procedure. And what do we see here? Well, the areas in green are these sites of ablation. Okay, so here they ablate around. Okay, we'll go in order. So they ablate around these right pulmonary veins, right? Just completely shut off these ganglionated plexi. They do one that's a little wider. They ablate around the superior vena cava, shutting down these ganglionated plexi. They ablate around these pulmonary veins. Now both pulmonary veins are kind of isolated, right? They're unable to spread their signal to the rest of the atrium. They are just kind of by themselves. So if a signal is produced right here, it can't go anywhere. It's stopped by that ablation line. And then lastly, you kind of clip the left atrium, or the left atrial appendage, or the left auricle. And we'll talk about that, of why that's done a little bit later on. But really look at what they're doing. Why is it called a maze procedure? Well, they're essentially creating a maze in which there's a fixed pathway for a signal to flow through, right? If a signal is generated right here, it can't flow out. If it's generated in any of these ganglionated plexi, it can't flow out. That means the signal has to follow the correct line that it's supposed to, right? It can, like, ectopic signaling can no longer move further and become arrhythmogenic, right? It has to stay in its area because it's isolated by the ablation lines. So I was able to find this diagram. I think this really helps. So looking at, what are we actually doing when we make these ablation lines? This is only like part of it. There are like 12 ablation lines. But essentially, what you're doing, sorry for the quality, but what you're doing is you're making this defined path that the signals have to follow through in order to get to the AV node. So the left atrial appendage blocked off, pulmonary veins blocked off. You can't just have extra signaling coming down. You can't have extra signaling crossing over. You can't have extra signaling arising from the atrial appendages, anything like that. You're creating this maze, right? That's why it's called maze procedure. You're creating a maze where the conduction has to follow through in order to go from the SA node to the AV node. So I hope that really helps to kind of explain what you're really doing. All these blue lines, the blue lines would be the ablation lines, right? So pulmonary vein isolation, look at them, they're in the middle of completely closed off by ablation lines. So you're isolating them so that, if this sends a signal, you don't also have this sending a signal, right? If this area of the right atrium sends a signal, it can't go anywhere. It has to go through the same pathway. if, any of these areas, if there's a signal right here, it has to flow through the same pathway so that you're mitigating the impact of ectopic signaling, right? Randomly generated signals have to follow the same pathway, so you're really minimizing how much those ectopic signaling, how much those can impact the rhythm of the heart. Okay, moving on, we're going to be talking about the intraoperative cardiac conduction system mapping for congenital heart surgery. So normally with heart surgery, you can just send them to an electrophysiologist lab and map out the conduction system, and then you'll have that map which you can use as you do like a maze procedure or something. But with congenital heart surgery, it's a lot more complicated, and so the necessity or the want for, not necessarily necessity, but the want for a like an ability to figure out where the conduction system is in real time kind of arises because of the complex anatomy, right? You can't just use the triangle of Koch to identify, yep, there's the AV node, if everything's getting twisted and develops improperly and you really are not sure exactly where the conduction system is. So if you're trying to, take a 3-ventricle heart and turn it into 3-chamber heart, turn it into a 4-chamber heart, you really want to know where that conductive tissue is so that you can preserve it. So we're going to be looking at 2 different methods. These are both really like cutting edge, what's happening right now, and it's really only being used for congenital heart surgery, just because of that complex nature of the anatomy, right? So first, we're going to look at the EPM, which is electrophysiological mapping, and then we're going to look at FCM, which is fiber optic confocal microscopy. So looking at the electrophysiological mapping first, I just want to go through this just so we're all clear on what we're looking at when we see an EKG. So the P wave, this is going to be the atrial depolarization. So we're going to see depolarization, it's going to be that contracting, right? So the atria is going to be contracting. And then the QRS complex is going to be the depolarization of the ventricle. And while this is happening, you would also see a repolarization of the atria, but it's kind of being, overtaken by this QRX complex, which is the depolarization of the ventricle. And then the T wave is going to be the repolarization of the ventricle. So P wave, move that away. P wave is going to be depolarization, atria contracting. QRS complex is going to be the ventricle contracting, the depolarization of the ventricle, and the T wave is going to be the repolarization. So, in terms of electrophysiological mapping, here's what we're doing. So, essentially, using a catheter like this, right, with nodes placed, okay? So A1, 2, 3, 4, B1, 2, 3, 4, okay? And so they basically apply it to the heart tissue. And what are they looking for? Well, they're looking for what's called a His bundle potential. So here's kind of a picture. They got this person, this electrophysiologist is essentially watching, and they're looking for a His potential. So moving on, you could see here we see like a P wave, right? And then here we see some sharp ventricular depolarization, so like that QRS complex. So anything between the P wave, where the atria is contracting, and the QRS complex, where the ventricle is contracting, anywhere between that is going to be like AV node, right? Just thinking about our pathway. Atria contracts, AV node delays the signal, ventricle contracts. So the His bundle potential is going to be this electrophysiological signaling between that atrial depolarization and ventricular depolarization. So that's what they're looking for. So again, remember we have this kind of grid schematic layout on the catheter so that when you lay it down, you can essentially see where's C? C is like near the top, right? So if this little bar is going to be C, then we lay it onto the tissue, and it's going to be like electrical nodes, and they're going to be seeing the electrical physiology of this tissue in certain areas of this catheter probe, whatever you want to call it. You're going to see an atrial wave and a ventricular wave, but then in the middle is going to be that His bundle potential, which is what they're looking for. So by seeing the His bundle potential in what the C and B, so like right in the middle, you would know that there's conductive tissues right here. Same thing here. We see in this C and B area, you would see this conductive tissue rather than the atrial and the ventricular like waves, right? So this is really one way of mapping out the conduction system, is laying down a catheter and seeing what's sending that His bundle potential, what's sending that conductive tissue potential rather than atrial muscle or ventricular muscle. What's sending the conductive tissue, physiological signal or electrophysiological signal. And based on that, we would know, okay, C2, C3, C4, B1, B2, and then to B3. So that's where we know, looking at the catheter, we know where it is based on the catheter. So that's one way of doing it. Now the other way I think is pretty amazing. It's essentially using fiber optic cables to see into the tissue, right? So I think we'll go over these pictures first, and then we'll watch a video of it if going on. But what we see is, here we're looking at different areas of essentially the atrium, right? So in A, it's going to be the working myocardium as we approach the SA node. And then B and C are going to be the SA node region. So what do we see? Well, we see that working myocardium is going to be very, striated. We see those lines, those harsh lines. So we know that this is going to be the working myocardium of that atria. What do we see here as we enter that sinus node region? Well, it's a lot more reticular, right? It looks like a net. It looks like this rather than that striated tissue. So we see a lot more reticular tissue as we enter this sinus node region. Okay. Now, what do we think this is? This is going to be that atrial tissue, but it's going to be kind of approaching the atrial myocardium, rather, like that working myocardium as we approach the AV node. Okay, so you see that striated appearance of the working myocardium. But look, this looks totally different. So this is going to be this AV node region. So we can even see a difference between SA node and AV node regions, but really both of those areas of connective tissue between SA node and then AV node, both of these regions are way more reticular in appearance than the striated working myocardium areas. So now we can look at this. Whoa. Whoa. Wait, oh my god. Oh my god. Who knew? Oh my god, I didn't know you do that. Okay. Click this. So we're going to be kind of approaching, working through the myocardium, and then approaching the SA node. And so you'll see the change. So did you see the change? So here, I play it right there. We're super striated, right? Very striated, clearly working myocardium. But then as we get closer, there we could totally see it's becoming way more reticular in appearance, right? You can totally see it looks way different. So we're very striated, very much so working myocardium. And then there, it's going to be turning into that SA node region, and you can see it's a lot more reticular, a lot less striated. So that kind of concludes in terms of talking about the ways in which there's this cutting edge technology of real-time intraoperative mapping of the cardiac conduction system. And again, this is really only being used in congenital heart surgery, dealing with congenital heart defects, because that anatomy is so complex. Whereas with a maze procedure, you can just take it to an EP lab and get a mapping beforehand, and then you can use a map during surgery. All right, so it's time to finish off this presentation by talking about atrial fibrillation. So I think this is one of the more interesting and very just complex, not complex, but just mystifying things that we're going to talk about. Okay, so what is atrial fibrillation to start? Well, if we look here, we're going to see EKG of the heart, and if we go back, comparing it to this, we knew that the P wave is this nice little hump. That's going to be the depolarization of the atria, right? And then this is going to be the ventricle contracting, which is kind of like that heart rate, the heartbeat, I guess. And then the repolarization of the ventricle. So the P wave is just going to look like this nice little hump. However, in atrial fibrillation, we're going to see a fibrillation of the atria, which is essentially just a seizing of the atria. So here you see that it's that P wave, or where the P wave would be, is just all over the place. It's just seizing, right? It's just going all over the place. And we even see that there's no regularity between the beat to the ventricle. It's all different distances, completely irregular. So it's just a seizing of the atria, where it's just signals just bouncing all over the place rapidly in every direction. And that's why you get this intense looking, like, there's no P wave. You can't discern a P wave. You see irregular heartbeats. It's just all over the place. Now, we talked about this a little bit when talking about the GPs, and we saw that, if we go back, we saw that the ablation is around the pulmonary veins, right? And we know that there's a procedure called pulmonary vein isolation, which is one method for treating atrial fibrillation. So why the pulmonary veins? Well, maybe pause the video, try to think about why the pulmonary veins would be this site of problem. Like why the left atrium and the pulmonary veins would be, an important site for this. But essentially, what it is so what are the pulmonary veins attached to? Like, what are they coming from? Well, they're pulmonary, so it's going to be the lungs, right? The lungs, and you can see it in this diagram. You have the lungs are going to have their veins, right, going back, the oxygenated blood back to the heart, and it's going to be attaching to the heart in the left atrium through these pulmonary veins, okay? So, there it is. So, if we're looking at the heart, right, this is anterior, flipping it to posterior, this is going to be the site of those pulmonary veins, okay? So, if my hand is the lung, I'm going to be attaching to the heart just like this, okay? So as the heart beats, what's going to happen to this area? Well, the ventricles and everything are going to contract, so it's going to go boom, boom, right? Flip it to an anterior, boom, right? Boom, boom. But what's happening at the site of the pulmonary veins? Every time it contracts, this is fixed. So this area, the site of the pulmonary veins, where they go into the left atrium, that is the fixed site of the heart. So the heart is a moving structure, except for that area where you have the 4 pulmonary veins entering the left atrium. At that area, you're going to have a fixed tissue, right? So if these are the pulmonary veins right here, okay, and, I can do this, boom, right? This is the fixed area right here. Or sorry, this is the pulmonary vein, then it's going to be holding almost just like this picture, right? It's going to be holding this tissue in a fixed way, right? It's just going to be holding it still. Whereas all of this is going to be free to kind of move around, okay? So you're going to see that this is going to be the problem area. So what starts AFib? So as far as we know, it's essentially thought that it's okay, wait, before I even say that, what's going to happen if the heart beats and one part of the heart, like right here, is fixed? What's going to happen to especially these tissues directly around the pulmonary veins? If this isn't moving and the heart is moving, you're going to see tension. You're going to see a stretch occur in this tissue. So you're going to see that since the heart is moving and forcefully contracting, you're going to see that this tissue of the left atrium is getting stretched. So it's thought that essentially there's no conclusive on why it starts there, but the working idea is that it's a fixed point, and the stretch essentially causes the triggering of AFib. So it's the motion of the heart against fixed structures that causes those areas to start triggering atrial fibrillation or to start sending a signal. It's the The motion of the heart against fixed structures. That's what starts the triggering. Okay? So with that, it starts at the pulmonary vein, but then what else happens? Well, this is the pulmonary veins and where they enter the left atrium are fixed. What else is fixed? Well, that back wall of the left atrium. So when the stretch keeps occurring, essentially as we grow older, every heartbeat you're getting a little bit more stretch, right? As the stretch keeps happening, scar tissue is going to develop in the back wall of this left atrium, and that keeps the AFib going. So you see that little fibrotic islands that are just scar tissue begin to form. And so this is why pulmonary vein isolation on its own, essentially just clamping off, or not clamping, but ablating around the pulmonary veins is not enough, because you're gonna fix the area of the pulmonary veins, but then that area between you're gonna fix here and around here. But what about all this? This is all getting stretched too. You're getting fibrosis all through here, right? So if we think about, even if you clamp off, sorry, I keep saying clamp, I'll just say like ablate around. So even if you ablate around and essentially isolate and nullify any signals that come from the left or the pulmonary veins, right, on either side, well, what else is happening? So you're getting, if we go, I'm not going to go back all the way, but think about that original anatomy of the conduction system that we talked about. You have the sinus node, but then we also have those branching, that Bachman's bundle that goes to the left atrium. So you're going to have a signal that's coming from that SA node and traveling over here, okay, into this back wall of the atrium, right? So if scar tissue is forming and you're getting little fibrotic islands on this this back wall, so what's going to happen with these fibrotic islands is that no longer is it just the pulmonary veins that are kind of the material where the AFib can occur, but the entire back wall of the atrium is going to be the substrate. So AFib is no longer going to become a triggered phenomenon, it's going to become a substrate-driven phenomenon. So I need you to understand what that means, right? We said that when AFib starts, it's a triggering, okay? So something happens with the stretch against a fixed moment against a moving heart, a trigger occurs. But then as the triggering occurs and as the stretch continues, you get fibrosis essentially of the back wall, and it becomes substrate driven. What's the substrate? Well, it's the material that the conduction is going to pass through. Essentially, in a normal rhythm, it goes from A to B, right? It goes from sinus node, Bachman's bundle, and then gets all this. All the left atrium is ready to go. It gets the signal and it pumps, right? It goes A to B. But when the fibrosis occurs, you get fibrotic islands. So now the signal can go everywhere because it's hitting these fibrotic areas, and they make their own circuits. So it's AVNRT, right? It's the same mechanism. It's fibrotic islands form. Like, let's say, okay, I'll do this. Let's say this right here. This is a fibrotic island where the red is, okay? So if a signal is trying to pass through the left atrium, it's going to hit this fibrotic island and it's going to go around it, right? It can't go through fibrosis. So it's going to go around it. But then what happens? Well, it's the same thing in AVNRT, where that signal is going to loop around and loop around. And then as it loops around, it's going to send a signal in all directions, right? Because it's just looping. It's creating this loop. So it forms these little micro and macro circuits in the left atrium as you get more and more of these fibrotic islands. So essentially you can imagine this, a signal coming in. Let's take this white dot so that I can kind of draw. So let's take this white dot and imagine this white dot right here is a fibrotic island. The signal's coming from the SA node through the Bachman's bundle, and then it hits this. And it has to go around. So it goes around, and it sends a signal this way, but then it keeps going around. And it sends a signal this way, and it keeps going around. It sends a signal this way. So you can see how a circuit is formed. And this would be one of the micro circuits, but you could also have more macro circuits, which would be, an island or essentially a circuit around the entire atrial wall or the entire atrium. Like the entire atrium becomes the substrate for atrial fibrillation. Like it's like unbelievable. Like the entire atrial wall becomes the material that the AFib can occur in because of the islands of fibrosis. I hope that makes sense. It's like the stretch causes fibrosis to occur. Initially, the AFib starts as a trigger, but then it becomes substrate driven, where the normal conduction from the Bachmann's bundle hits the fibrotic islands and loops, and it forms a circuit. And the circuit doesn't just disappear, it sends signals everywhere, right? It just loops and loops and loops, like what we saw with AVNRT. It's the same thing. And even you see there were studies done with MRIs where you see that the scar burden on the left atrium directly contributes to the AFib burden. Increase in scarring, increase in AFib. It's directly contributing, or directly correlated rather, but contributing. And so what this means is that the substrate becomes the entire atrial wall. So there is no cure for AFib. What do? You can only burn so much, right? That's what the maze procedure attempts to do, but there is no cure for AFib. You can only control AFib. The trigger happens, the stretch occurs, the trigger happens, and with that stretch, you get fibrosis. So there's no cure. This is why, and this, the fact that the entire atrium becomes a substrate, this is why pulmonary vein isolation is not enough. What's significant clinically about this is that the maze procedure should be earlier, is kind of what I'm trying to get at, right? Pulmonary vein isolation is not enough. Simple ablation is not enough. It seems as though, once you get AFib, you have, your heart unlocks AFib, okay? And then just isolating the pulmonary veins won't help because you're going to see fibrosis in so just isolating here and here won't help because you need to burn all this because you're going to see it happen right here. And then you're going to see it happen down here. You're going to see that whole atrial wall become the substrate or the material where the signal can pass through. So the maze procedure essentially needs to become the earlier intervention. But that's a problem when you have somebody who gets AFib once a week, right? It's paroxysmal, it's early AFib, and you say, hey, you have AFib once a week and it doesn't even last a week, but let's open you up and we're gonna burn here, and do all these things, right? It's very difficult. However, pulmonary vein isolation is much less invasive, more minimally invasive. You just go through a catheter, or it's a little different. But essentially, it's way, normal ablation is so much less invasive, but it won't do the job. You need to make the maze. You need to force the conduction to follow a path because that whole atrial wall becomes the substrate. So if I go back to here, if the entire atrial wall is becoming the substrate for the AFib, you need the maze. You can't not have the maze. You can't just isolate the pulmonary veins. You can't just burn some of the endocardium or the epicardium and hope that it won't do anything. It won't do the job. And with this, I did forget to mention this, but essentially the pulmonary vein area starts the signal, right? That trigger. But the sympathetic triggers in the fat pads, which are what? The ganglionated plexi, those are important in keeping the AFib going. Okay, so I did want to touch on that. But again, it's this mechanism of the fibrosis occurring because of the stretch of that tissue. Fibrosis occurs and then the circuits form. Like we talked about how AVNRT works, it's the same thing. You get mini circuits, and then every time they're looping, they're sending signals. So that's what forms this seizing. Okay, I think that's it for AFib. Oh, one more thing. So we saw here, what do they do with the left atrial appendage? Well, after a period of atrial fibrillation, the heart is still. So there's a period of stillness after atrial fibrillation. So what happens is blood collects in the left atrial appendage, which means if the heart's still and it collects in the left atrial appendage, it's going to embolize and clot. So AFib is a huge risk for stroke. So a big, huge thing in AFib and interventions relating to AFib are going to be clipping that left atrial appendage. And what I mean by clipping is just closing it off. Not chopping it off, but just closing it off. So just closing the left atrial appendage so that no blood can get into it. And really, what's really interesting is that essentially post-op AFib is a massive problem. And we're not going to talk about why that is, but essentially post-op AFib is so common that it's beginning to be thought that maybe we should clip the left atrial appendage for every heart surgery because of AFib occurs, period of stillness, and then the blood collects in that left atrial appendage. But at the same time, if you clip the left atrial appendage, then you're going to be getting more pressure inside the left atrium, more pressure, more tension, more problems, right? It's the same thing. So I think that's it. So that's about it for atrial fibrillation. And I'm going to touch on it again when I conclude the presentation. But I do want to say thank you to Vika Sharma, Dr. Vika Sharma. He's a cardiothoracic surgeon at the University of Utah. And I met with him and talked about a lot of the topics in this presentation, but really what he said about AFib was especially informative and, pretty amazing information. So I really want to thank him. So just to conclude, here's what we talked about. This was in the plans, but essentially we did overview, talked about that basic anatomy that we learned in class, and then we did the anatomy, the more current look at anatomy. We talked about the physiology of conductive tissues, why they're special. We did overview of development, talked about how the heart forms and why it's significant. And then we went into depth on the conductive ring tissues. We talked about the AV node and how AVNRT works. Talked about the slow and fast pathways. This was a little earlier, before all this, but we did the His-Purkinje system real quickly. We talked about the ganglionated plexi or plexi. We talked about the strategies for mapping the cardiac conduction system while you're in surgery, especially for congenital heart surgery. I think it's pretty amazing. And then we finished up with atrial fibrillation. Now, moving forward, really to conclude this presentation, I want you to think about how do we solve AFib, right? What kind of rings in my head is that it's like cancer, right? We age too long, we live too long, and so we get cancer, right? We live long enough to where things just mutate, and it's the same thing with atrial fibrillation, right? You live long enough, you end up with this scar tissue, and you get these circuits which form AFib, right? So how do we solve this problem of the stretch? How do we solve this inevitable or seemingly inevitable structure of fibrosis and the atrial wall becoming fibrotic? I mean, what do we do? Do we just do a maze procedure the second anybody gets any type of arrhythmia? No, but I mean, that's what it seems like we should do, right? Just immediately, as soon as possible, fix the pathway. But I don't know, what do we do to fix this seemingly inevitable result of the structure of the heart, right? Fixed pulmonary veins, moving heart, tension. What do we do about that? I just want you to think about that. I think it's really interesting. Yeah, I mean, that's pretty much it. Thank you for listening. I hope this was informative. I hope it was... I know it was informative. I know there was information, but I hope it was understandable. Yeah. Thank you very much. My name is Ian Ayre once again. If you made it this far, comment. If you made it this far, like and subscribe, and comment what your favorite muscle is. Thank you very much. Yeah, have a good day.